Again, good morning, everybody. Thank you for coming. What we're going to be doing today is kind of just jumping off where Ted left off a few minutes ago when he said that, you know, it's been recognized that housing is health care. And so finally, everybody agrees with that. And then he asked the question, so how do we get health care to pay for housing? And, you know, that's a really great question. That question leads to the issue of reimbursement and the trend that we're moving towards, which is pay for success, performance-based reimbursement. And a lot of us in housing aren't used to that because we're used to getting, you know, a grant. We're used to a contract with a certain amount of money, and that may not be the case going into the future. So when you ask yourselves, well, okay, so what's performance, or what are the objectives? It's in this world where we're saying that housing is health care. The performance is keeping people healthy, keeping people in the community, keeping people out of emergency rooms and hospitals whenever possible. And those are the keys to bending the healthcare cost curve, which is the primary priority. That's redundant. It's the priority of our government partners. It's the priority of managed care. It's the priority of the healthcare world. So our priorities haven't changed, though. Our priorities are to keep people healthy as well. Our priorities is to provide people with the tools and the support they need to pursue their recovery. And so the bridge between our priority and the new priority, which is bending the healthcare cost curve, is what you're going to hear about today. It's about being able to measure what we do, being able to demonstrate that we're effective in what we're doing, and being able to show that people who are in our housing, who are the beneficiaries of our services, are healthier and are less dependent on institutional care. So you're going to hear from this illustrious group of panelists about an innovative approach to doing that. And let me introduce them to you. Anat Leonard, LCSW, Deputy Executive Director of Housing Services at BRC. Anat is responsible for the overall management and operations of 7 programs, including congregate and scatter site permanent supportive housing. She holds an MSW from Columbia University. Heather Donahue, MSW, Program Development Coordinator. Heather is responsible for the design, development, and implementation of evidence-based programming agency-wide. Heather holds an MSW from Columbia University, specializing in social enterprise administration. And Lynden Bond, LMSW, Crisis Coordinator at BRC HomePlus. Lynden provides an additional level of clinical support to tenants who are currently experiencing a crisis situation within the HomePlus supported housing program. She received her MSW from New York University. Welcome, panelists.
Thank you.
And this is me. Anat?
Good morning. Let's see how this goes. All right. So we're talking about how our tenants are really doing and how we look at that at BRC. Okay. All right. Ooh. How's that? Better? No. I can't get any closer to it. All right. At BRC, we help people reclaim lives lost. We restore hope and dignity by offering opportunities for health and self-sufficiency. BRC today is a $65 million organization with 27 programs throughout the greater metropolitan area. It's over 1,700 beds of housing. We have a homeless outreach program, actually several, substance abuse services, and workforce development. More than 7,600 times last year, an individual in need said yes to BRC and walked through our doors. More than 5,100 times, a BRC client successfully graduated and moved forward to reclaim their life. BRC has a performance management focus. We maintain a rigorous agency-wide performance management program to track and measure program outcomes. On a daily basis, we consult and utilize data. We run reports on a monthly basis, and on a quarterly basis, the program directors and senior management gather to review performance data. This integrates planning, management, and leadership and governance into the process of evaluating program effectiveness. BRC offers a number of permanent supportive housing programs. Clyde Burton House is 33 units, Glass Factory is 45, Liberty Homes is 46, and that's singles, couples, and families. Los Vecinos is 35 units, the Palace SRO is 24, and HomePlus is 330 units. HomePlus is our scattered site permanent supportive housing program with apartments in Manhattan, Brooklyn, and the Bronx. There are 174 units funded by OMH, 41 DOHMH scattered site units. Both of those, OMH and DOHMH, are New York 1 and 2 community care level approval. We have 90 DOHMH funded units for Category E, those are active users, and 25 OASIS funded Category F units, both of those under the New York 3 agreement. We sought a peer-reviewed tool to quantifiably measure outcomes in permanent housing, including the stability and functioning of tenants living in the community. We wanted to measure the effectiveness of our service provision amongst the programs, to measure gains in tenants' levels of independence over time, and we wanted something to complement our service planning and person-centered approach. We used a number of criteria in our selection process, including the cost of the tool that we were using, what type of methodology was used. It was important to us to have a focus on brevity. We wanted it to be something that could be utilized and wouldn't be burdensome to the staff or our tenants. We needed it to have electronic capability, and we've actually embedded the tool that we've chosen into awards so that all of the data we collect is usable and reportable. And we wanted something with a holistic approach. The Multnomah Community Ability Scale, which we call the MCAS, is a standardized mental health assessment that assesses symptoms, functioning, and the behavior of adults who have a serious mental illness and live in the community, and it is available through the public domain. The tool measures functional ability through 17 indicator items. They're rated on a 5-point scale and are grouped into 4 sections. The health section focuses on physical, mental, and emotional symptoms that interfere with daily functioning. Adaptation includes the abilities for coping with mental illness and living in the community. Social skills encompasses how people with serious mental illness interact with others. And behavior includes actions that affect community tenure and positive service outcomes. The MCAS was first created in 1983 by mental health case managers in Oregon. So we complete the tool upon a tenant's intake into our program, and then we do it in conjunction with our quarterly service plan reviews, and we also complete the MCAS at discharge. We use a semi-structured interview at intake to learn about this new person that we're working with. And the tool rates the level of functioning within the past 30 days. It is a point-in-time snapshot that we're looking at. It takes about 10 minutes to complete. And when rating, we compare our tenant to the total population of people with serious and persistent mental illness, not to the general population. The tool is normed for the folks that we're working with. So tenants are scored as high, medium, or low functioning, and it's based on the actual numerical value or rating of our assessment. A high score is a total score of 63 to 85. 85 is the maximum score on the tool. Medium score is between 48 and 62, and low is between 17 and 47. Any item with a rating of 3 or less is considered clinically significant, and it can help us identify treatment goals. And quarterly, if there's a score change of 10 or more, that indicates a significant change in functioning, and also highlights folks that we might need to offer more support around who are potentially decompensating. So we launched using the MCAS tool at BRC HomePlus, that's our 330-unit scattered site program, in the fall of 2011. We expanded it to our moving home program, which is a scattered site safe haven model, in the spring of 2013. We expanded again to MAP, which is our scattered site CR model, in the summer of 2013. And then we began using it in the rest of our congregate housing programs this fall. We expanded the scope of the use of the tool by 90% in 2 years.
Can you hear me? No? All right. I'll hold it. What about now? Yes? Better? Okay. Hi, I'm Lynden. And I'm going to speak about how we implemented this tool at HomePlus permanent scattered site supported housing within BRC. So first I want to speak on the challenges we had with implementing this tool in our program. A few of the challenges that we encountered were getting the staff to actually buy in to using this new tool, understanding and learning what the tool is and how to use it correctly, as well as managing rater bias. So one of the biggest challenges we had within our program and beginning to use this tool was getting the staff excited about it and buying into actually using it. At first, there was a lot of opposition to using this new tool. Previously, we used a checkbox, yes or no, functional assessment, very quick and very easy, and we moved into using the MCAS, which is 17 very specific questions, which requires to know a lot about our tenants and specific behaviors and symptoms that they're experiencing. So furthermore on that, it makes it so it encourages difficult conversations with our tenants. Since we need to know a lot of information, we have to have conversations about their acceptance of their psychiatric disability, their current substance use, if they take their medication, and any medical issues that they have. These conversations were being had prior to using this tool, but once we implemented it, we really needed to get more details so we could accurately score our tenants with this tool. Lastly, using this tool requires more service planning than our previous functional checkbox yes/no assessment. Any item with a rating of 3 or less is considered clinically significant, and we use that to help identify treatment goals. The way we do that in our program is any item scored 3 or lower is mentioned on the service plan, whether that's in the limitation section or as a specific goal. So obviously our tenants who are lower functioning, who have 3 or lower on a lot of different items, may have a lot more goals than previous to implementing this tool. Another challenge we encountered when implementing this tool within our program was just learning how to understand the tool. It's a very specific tool, and there's a lot of information that you need to know when using it. The scale is not intuitive. It's not a Likert scale, and it includes many variables. So you actually have to use the manual every time while doing it. It's not just yes, no, yes, no. So we've really worked with our staff to help them understand the tool. and how to use it to show improvement with our tenants. One of the challenges we found was that if a tenant shows improvement, staff wants to bump the score up from maybe a 2 to a 3 or a 3 to a 4, where that's not always the case. Each score has a specific set of behaviors and symptoms associated with it, and although someone may be improving, they'll still fall within that same score. So what we did to kind of work around this challenge, we've helped staff to show client gains in other areas, whether that's in the strength section of the service plan or in other charting. Lastly, when we started using this tool at HomePlus, we found that there was a lot of rater bias when scoring. When we did the initial data review, we found that a lot of our tenants were shown that they were high functioning, when in reality, and when working with them, we knew that maybe they weren't quite there. So we spoke with our staff and we found that they were saying things like, oh, he's so nice, like he's doing so well, and that's why they rated them higher. So this led to a discussion that a client's current level of functioning and stability has nothing to do with how nice they are or how far they've came. It really is just a point-in-time snapshot of their level of functioning within the past 30 days. And so now that we've been using this tool for a few years now, our scores have normed out, and it's really showing where our tenants are at currently. So although we did have some challenges, we've had some great successes in our program with implementing this tool as well, including improvement in the quality and creativity of service planning, improvements in our teamwork and professional development in our program, as well as just improvement in the way that we review lower scores. So as I mentioned before, with implementing this tool, it has required a lot more service planning. While this has been a challenge, it's also been an opportunity for us to be creative with our service planning because we have a greater level of understanding of our client functioning. It allows staff to discover new areas of improvement that were previously not addressed. There are 17 questions on this tool, ranging from social skills to adaptation to how often they take their medication, and this really allows us to focus in on specific areas that we can address with them in their service plans. Service plan goals are more individualized and tailored to the client because each tenant has a different score on the MCAS. Each tenant has different areas that may be scored 3 or lower and that may be clinically significant that they need to work on. So overall, we do have a more holistic and comprehensive understanding of how each of our clients function in the community. The overall score gives us an understanding of their current stability and functioning within our program and within the community. Another success that we've had is just our overall teamwork and professional development within our program. When we first started using this tool, it was reviewed weekly with the supervisor and the staff one-on-one in supervision, but we found that it actually makes more sense to review it as a team, so we do that in monthly team meetings now. And how that works is the rater presents the score and tells the staff and the team a little bit about the tenant, and then we discuss it as a team and kind of focus in on scores that may not be accurate and see if we can get the most accurate scoring based on that tenant's current level of functioning. This assists with understanding the scale methodology, rater bias, and accurate scoring because there's a greater discussion than just one-on-one, and we can use the experiences of all the staff to focus in on that score and make sure it's accurate than just the case manager's interactions with the tenant. That being said, it improves communication among the staff. The staff have a bigger stake in all HomePlus clients. We found that there's more input when we do it as a group, and that while the case manager may have one experience with their tenants, the tenants could act a completely different way with another case manager or another staff member, and we want that to be shown within the tool and within the overall score. Lastly, when asked about an indicator rating, staff are better able to support their answers and show insight to client behavior. It's really great now when staff bring the MCAS to the team meetings to discuss. They come prepared with their manuals, and they come prepared to explain why they gave a tenant a particular score on a specific area. And they're more excited about saying, I knew you'd ask that, let me tell you why I put this score, and they have clinical assessments to back that up. We've also had successes in the way that we review low scores in our low-functioning tenants. Currently, management staff complete a review on a regular basis to go over the lowest functioning tenants. So the way we do this is we ask our case managers to identify who they feel is low functioning, and then we also speak with the program director and look at her recommendations for who she thinks is low functioning, and we discuss it as a management team. This serves as an additional check-in for low functioning tenants to make sure that the people who we see on a regular basis who are experiencing maybe not so much stability and may be low functioning, we're actually rating them as low functioning with this tool, and it serves as a QA check for our MCAS scores. We're also able to highlight trends or specific questions that are red flags for lower functioning tenants. So tenants who may need further support may be scoring lower on specific questions such as engagement with treatment or medication management, so we're able to see if there's any correlation between that. We've also created my role in the program, crisis coordinator, to assist with the low functioning tenants. So once we've kind of determined who is low functioning, we can go in and intervene and provide extra support as necessary to make sure our tenants stay out of the hospital or get the services they need to live in the community. Oh, it turned it blue.
So again, in the fall, we expanded the use of the MCAS tool to the rest, or to our congregate supportive housing programs. This was a pretty smooth transition, and in some ways, I think we started with our biggest, most moving parts program, HomePlus being scattered site, being funded by multiple funders, and being across 3 boroughs, 2 offices, lots of staff, lots of moving parts. We were able to learn a lot, and so the implementation for our congregate programs, which are much smaller, so fewer tenants, went very smoothly. This was evidenced by the staff feedback. I think initially HomePlus staff were a bit of our guinea pigs in terms of the training and how we were implementing the tool and working through the process together, whereas with the congregate programs, we had a better sense of how to successfully implement the tool, and the staff really felt that difference. We found that the congregate programs had a quicker normalization process of the scoring because we knew how to do the team review, or the impact of doing the team reviews would have on rater bias. And so we were able to move kind of quicker through that startup phase. We also had clear evidence that this tool really worked for our population and for our agency. And we tailored the training program to meet our needs. With the recent expansion, we began using the tool outside of its evidence base as a BRC best practice. So the MCAS was designed for folks with SPIMI Axis 1 diagnoses. And pretty early on, we started using it also for folks with substance use disorders as an Axis 1 diagnosis. And then more so in our congregate programs, because of the criteria for folks when they moved in, we began using it with individuals who only had medical disabilities. So no Axis 1 diagnoses involved. This only directly impacts one question on the tool, which is the acceptance of a psychiatric disability. And so we found that the MCAS is still an effective tool with the range of scores. These folks, the folks who don't have an Axis 1 diagnosis, are not exclusively high-scoring folks, and we're able to identify their challenging issues. So a case vignette to bring this alive. Joe has been in supportive housing for over 10 years. He has no history of substance abuse or mental illness, always pays rent on time and without prompting. His eyesight and hearing are failing, making it increasingly difficult for him to act with his neighbors and staff. His case manager noticed that his room is getting increasingly dirty, and we've become aware that his room is infested with roaches. So although Joe does not meet the eligibility criteria for using the MCAS tool traditionally, we're still able to use the tool to identify areas of improvement. We're able to use it for service planning and to set unique goals, specifically around socialization. And these make it and including how to make it easier to communicate and socialize with neighbors. Although Joe used to come to groups regularly, he doesn't enjoy attending anymore because of his limited hearing, and will come to major events with staff prompts. He was prescribed a hearing aid, and staff encourage him to use it. And that allows for some increased socialization and program participation, as well as engagement and treatment. The MCAS also highlighted other areas that Joe could benefit from addressing, and we could see marked improvement in several areas. It helped us pinpoint areas around his daily functioning, including the inability to interact with others that led to his increased isolation. Joe's scores fall within the upper medium category of functioning, and they've continue to be strong in the areas of thought processes, cognitive ability, and ability to manage money, but can still improve in areas such as social interest and meaningful activity.
Hi everyone, how are you? My name is Heather Donahue. I'm the Program Development Coordinator at BRC. That means I'm the data person. Do we have any other data people in here? Huh? Okay, a few. So I'm talking to you guys. I'm going to convince the others that this is what you want to do. So we've been talking a lot today about how we can use it within the program, how we've implemented it, and now I'm going to show you what we can do with the actual numbers. So we hold a quarterly evaluation meeting with our senior management staff. We do that with all of the permanent housing programs and then separately with our transitional programs as well. And when we're doing these meetings, we're discussing how the implementation is going, yes, but also we're looking at each of the different data points. We can use this to improve the programming around if we're completing it correctly, if we're completing all of the ones that we want to complete, and we can also look at how we're doing aggregate and also individually. So in terms of aggregate data, I can pull reports on the completion rates. So that's, are they going to be completed with the service plans like they're supposed to? And every person that has an MCAS due, are they being done? I also can look at the category of functioning, high, medium, and low. And I also can look at the average scores in program. I can break it up by funding source, and that's always interesting to look at. And I can also break it up by contract type. So for our HomePlus program, for example, we have both substance use and mental health programs. So it's interesting to look at the comparison between the two and see how the tenants are rating. And lastly, I can break it up by the average score per section. So those, no. Okay, so those are health, adaptation, social skills, and behavior. Hello. Okay, we're back. And on an individual basis, I can track their quarterly total scores, their section and question, and then I can also measure how they fluctuate in terms of their category of functioning. So this is my big ugly. When I pull the data, this is what it looks like. As you can see across the top, those are going to be the averages, and I run this for about 200 people a month for the HomePlus program, and then quarterly probably about 500 or 600 for the agency total. So you can see across the top the average for the total scores, each of the sections, and also the questions. And what's interesting to look at for the questions is oftentimes certain programs will have a question that is lower, and that's a really unique opportunity that you can really target programming around that specific section. So whether it's meaningful activity activity, you can have more outings, more socialization. If it's ability to manage money, you can have more workshops around that topic. And each one of these lines is an individual tenant. And if we track this over time, we can see the fluctuations on each of these points. And that's also rewarding to staff, right? Because if there's an area that's indicated lower, and you make a service plan goal for that, and then next quarter, when you do the MCAS, you can see that that is actually changed, that's actually a really great motivator as well for service planning. All right, and this is our HomePlus program. This is just an example of the breakdown of percentage for functioning. So as you can see for this, there are 74% high functioning, 24% medium functioning, and 2% low functioning. And that might seem high, but you have to remember that we're comparing these people to the total population of individuals with serious persistent mental illness. This isn't the general population. So if they're in a supported housing apartment, it might make sense that they're higher functioning. And this is how we look at it over the year. So we can track our data over time. And as you can see, there's a little dip. It usually goes a little bit lower after we did a training, and that's because it's more norm to the scores. But you can see it's pretty much consistent within the range of, does that say 65 is the lowest, 74 is the highest. So we have these numbers. What are we going to do with it? On an individual basis, we can monitor these fluctuations and provide additional services where indicated. I'm going to show you a graph on the next slide for that. And these are real clients. So I think these you can see better. There's purple for Mr. B. He's a HomePlus tenant. As you can see, he starts out at about a 68. That's high functioning, right? Second quarter, he's about a 70. The third quarter drops to a 68 again, I think. And the fourth quarter, he's back to a 70. That's well within the normal range. He's stable. If you look at the green line on the bottom for Miss C, she starts at a 65. That's considered high functioning. For the second quarter, she drops to about a 62, still high functioning, nothing that we really would be looking at. In the third quarter, she drops all the way to a 52. That's a 10-point drop, and using this tool, that's considered clinically significant. And the interesting thing is this is actually when she was psychiatrically hospitalized. So this shows that the tool tracks these things, and when we get her back into the program in the fourth quarter, she is back up and within the stable range. So over time, once we've been using the tool longer, we're going to be able to use this as a predictor for hospitalizations and hopefully be able to intervene prior to and to support the level of stability before they get there, because we don't want them there, right? Please don't go there. And then just as another point, you can see the blue line is how the HomePlus program has done throughout the year, which is relatively stable. And back to this slide. We created high, medium, and low functioning profiles to help target our interventions and inform our services. And what we did was we took the most common traits for everyone that was high functioning, medium functioning, and low functioning, and we developed these profiles that we're giving to staff. And through that, they're able to see different themes and interventions that are most effective for that particular level of functioning. And I also want to say that just because they're high functioning doesn't mean we're like, okay, you're fine. We don't need to worry about you. They're giving the same level of service, but we just give additional levels of support for lower functioning tenants. And that's where Lynden comes in HomePlus, being able to provide that extra level of clinical support where indicated. And the last intervention is something that we're working on currently that I'm actually really excited about. BRC is creating our own matrix of indicators. So there's 17 questions, and we're working together to pinpoint, so out of the low functioning tenants, what are the most common questions that are very low? And if we can combine these and create maybe a matrix of 3 or 4 questions, we can track this over time, and if there's a very low score on the matrix, then we can give the additional level of support that those tenants need. We're still developing that, but so far we've had great results. We ran it by all of our low-functioning tenants, and lo and behold, the scores were all very low on those particular items. Okay. And I think this is my last slide. I just want to show you how we're able to track those quarterly changes in stability that I spoke about. So this is the template that I created, and you can see in column B, so that's their first quarter MCAS, and in column C is the second quarter score. So each of these tenants are on our low functioning list. These are the clients or tenants that Lynden is specifically working with. And we can track over time because we're looking for that 10-point differential, right? So all she has to do is paste in the scores, and the spreadsheet calculates the difference between the first and second quarter. It highlights it for her if it's a tenant that she needs to be paying extra attention to. And this is just an additional way that we can look at the quantifiable data in terms of measuring and supporting their stability. Oh, this is my last slide. Okay. So we run monthly reports on all of our programs looking at a myriad of different things. And one of these things that we look at is number of tenants stable. So since using this assessment, we've really kind of changed our interpretation of how we see stability in terms of our monthly data report. So previously, we had a list of symptoms, attributes, behaviors, such as has paid rent for 2 months consecutively or could keep room clean. But that has a really high level of discretion, and so it wasn't really consistent across the agency. But now that we're using this tool, we're able to quantifiably measure the stability. So we say tenants above a high functioning score or who have a high functioning score, we put them as stable. And after we did this, we saw the number of tenants stable fluctuate. Do you want to guess which way it went? Down. It went way down. But what that really is showing is it's more accurate. So if we have a high number that doesn't really mean anything, or do we want the number that's accurate and might be a little bit lower? It also really enriches the whole conversation around what stability means. Instead of really just having the checkbox, this is, okay, they're stable if they can do these things, really having individualized data that we can track, I think has also really increased the quality of our data as a whole. Thank you.
All right, so as Heather mentioned, one of the ways that we track stability in our tenants over time is by monitoring their scores over time on a quarterly basis. And I just wanted to give an example of how we do that on the program level. So every quarter I can run a report like Heather showed, showing tenants who have score differences of 10 or more between quarters, and that's considered clinically significant. This is just a case vignette showing our tenant MP. He's been a HomePlus tenant for over 3.5 years, active substance user, cocaine and alcohol, but had no history of another Axis 1 diagnosis. So when running these reports, we found that between quarters 2 and 3, he had a significant change in functioning in his overall score. You can see on the bottom it went from 70 to 50. And upon further exploration and meeting with the case manager, we actually found that he had been recently hospitalized due to being disoriented, confused, not eating, and that he really needed a higher level of care in that period. So looking at these scores on a regular basis, it really does show that if we're accurately scoring how our tenants are functioning and how they're doing, we can provide support when needed. And now with this tenant, we can provide additional support to make sure he doesn't end up back in the hospital. So within our program, within HomePlus, we've had some great overall programmatic gains. We can now analyze behaviors and symptoms in a deeper context than only the disease. So before we were looking at Axis 1, you have a diagnosis, what's that kind of just looking like in the person and the way you're experiencing working with them. Now we can measure this over time. We can look at 17 different areas and how their stability changes over time and what their impact on functioning is with their behaviors and symptoms that they're currently experiencing. We also have the ability to abstract the information captured in the scale to see the true impact on supported housing by looking at changes over time and to see if the longer they've been in the program, if their scores are getting higher and they're increasingly, higher functioning or more stable. Lastly, we can use the knowledge gained to inform our programming and continually develop programming to meet clients where they are. BRC is very client-centered, meeting the clients where they're at. So based on all of the scores, the 17 indicator items, as well as their overall score, we're able to target our interventions and the services we provide to make sure that we really are meeting the clients where they're at.
Use the chair.
So moving forward, we'll continue to implement and support the evaluation process that we've described. Our data goal is to reach 95% completion rate for a point-in-time count in any given month. So that's across every program, across every contract, and on an agency-wide level. On a clinical level, we're working to support tenant stability and intervene before tenants are in crisis or hospitalized. And that's really referring to creating the matrix that Heather spoke about of indicators that we found are most meaningful to our tenants to try and provide that additional support. So takeaways and recommendations for you all. It's important, really essential, to find a tool that works for your agency. The MCAS works for us, might work for you. It's important to be prepared to manage the change in programming and staff expectations. Over the last 2 years, there were lots of questions around the implementation and why this tool and how are we doing this tool. But I think at this point in the game, the case managers who are using the tool on a daily basis really find value and meaning in the tool. It really informs their work and also really enhances their clinical assessments and their skills. The tool has both administrative and clinical implications. And as we've learned and continue to learn, implementation is an ever-evolving process. We don't ever want to say we've done this, we're at the highest level. We're constantly being informed with what we learn from the tool and how we can work to do it better.
Thank you. I think that was very enlightening, certainly for me, and I imagine. I said thank you. I said that was very enlightening for me, and I'm sure for many of you. So this is the time where you get to ask questions. Okay, we have a hand right there. Yes.
Thank you. That was a very thorough, well put together presentation.
Thank you.
I had a question. One of you said something about you highlight trends for your low functioning clients. And I actually have two questions.
Okay.
But one was, what are some of the trends that you noticed? And also, you talked about gathering all the information and doing an assessment. And my question to that is, how does the assessment that you do, based on the data that you collected, differ from what a clinical social worker might do, the clinical assessment that they would make in working with a client from day to day? I mean, other than, and you may have answered that question, I'm not really sure, but other than, being able to quantify what they do from day to day.
Yeah, I understand. Okay.
Thank you.
Okay, I'm going to do the first one first. So when we're building the matrix, we look at a lot of different factors. One of the main ones that we saw was engagement with treatment coupled with certain things. So engagement with treatment itself might not be the biggest red flag, but when engagement with treatment was coupled with substance use or loss of impulse control or medication adherence, and when you had those combined, we found that indicated a very low level of stability, because if they're not engaged with treatment, then they're doing it themselves and they don't have that extra support that they may need. Do you want to add? What else did we find? I think that's the main one. Do you want to take the second part about the difference between the clinical?
Sure. So what I can say is that our case managers are not MSW staff. They're not licensed clinicians. And so this is a tool that really helps our case managers be more informed about all aspects of a tenant's level of functioning. And so it really kind of supports staff from a ground level to dig a bit deeper and likely outside of their comfort zone, to have a holistic understanding of where tenants are at in their functioning and what's going on in their lives. We can use it on an administrative level to kind of identify trends or catch red flags, to support staff around that too. And what we found from Lynden's case vignette is that she was able to see what a case manager was experiencing with a tenant, and so those really lined up.
Okay, thank you.
All right.
All right.
We have back there.
Greetings. So I'm curious, you talked about staff buy-in. I'm curious about the program participant buy-in, because it probably was a change for them as well. And I'm also curious in that language. So we're using high functioning, low functioning. I'm curious if that language is used with the participants.
Hello. So we actually don't involve our tenants. Oh, great. We actually don't involve our tenants in using this tool when we use it. This is something strictly on the case management end. Obviously, the tenants are involved with service planning and their service plan, but this tool and the MCAS overall is something our case managers do, and it's just more on a administrative kind of level, and we use it in conjunction with the service plan where our tenants are involved in. Does that make sense? So they're not kind of aware that we're identifying people as low functioning or medium functioning. They just see kind of the services that we provide. Does that make sense?
Yeah, I also want to add, I think that, they're involved in some way because it's forcing the case managers in a good way to have conversations about topics that they previously weren't having conversations about, the difficult ones that we were discussing before. And so in that way, the tenants are very much participating in the receiving of the services that we're identifying, but we do not complete this assessment with them.
So, our question is, when you do this MCAS, right?
Yes, ma'am.
When you
Can
do
you
the
hear in the
MCAS
back?
No, stand up.
You're like, no, I didn't want that.
No, I can't do that. No. So when you do the MCAS, do you do the MCAS and the function conjointly with the service plan, or you do it separately and then months later you implement it in the service plan? Like, how do they link?
So we complete the MCAS prior to the service plan, usually within a week, right? Or something like that, or two. And we want to do that because we use the information from the MCAS to do the service plan. So it's ideally completed before, but because of the 30-day window of the MCAS, we wouldn't want to complete it more than a month prior to the service plan.
Hold on a second. Hold on. Go ahead.
So, I thought I heard you say that if a person scored below a certain number, like below 3, that item was then put on the service plan? Is that correct?
It informs our service planning with the tenant. So.
Can you explain a little bit about how that happens then?
Sure. The MCAS tool, as a validated and reliable tool, the creators of the MCAS have identified that any indicator with a score of 3 or less is clinically significant, right? And so then we take that information and explore with the tenant what's going on with you currently, what's going on with you in general, that you have that you are having some struggles in that area, right? So maybe it's money management, and a score of 1 translates to you spend all your money the day you have it. You essentially have very, very poor money management skills, right? So we would want that to be noted in the service plan, and if the tenant is interested in working on that, we would join them in developing a goal. If they're not necessarily interested in working on it, we would still include it in the service plan under a limitation, because their ability or inability to manage their money, pay their rent on time, purchase food throughout the month, is something to be noted and is clinically significant.
Could you
Multnomah, community, ability, scale, revised.
Revised.
You want to spell that?
Multnomah is a county in Oregon.
Go to the slide.
Yeah.
I thought about how I find this entirely fascinating. I'm always, I'm not a service provider, I'm just an affordable housing developer. And I was wondering have you thought about, I like how you changed into other groups outside the norms. Have you thought about how you could potentially look at stabilization for housing in general, how housing stabilizes families? And if you're, like myself, trying to make strategic partnerships to bring certain services to my residents, as a way to understand what those services should be. Have you thought about that at all, or is the whole
Well,
big order?
it is a big order, and we have been asked before, is this something funders should use? Is this something that programs should be scored on in terms of how stable your tenants are, and therefore you're doing good work, and we should give you more money to do more work? I would really caution people around that. Our tenants are our clients because they have ongoing disabling conditions where they need our support in order to live in the level of housing that they're in. Even with the best services, the most resources, even in a perfect world, sometimes our folks are going to decompensate. And so I would really caution folks against making some judgments around a tenant's level of functioning and that translating into a program or provider doing good or not so good work.
Yeah, I'd like to just add a little something to that. I think it has more to do with, as you said, how the tool informs the staff about what services to provide. And if that's working, then the outcomes are going to be that the person is going to be overall healthier, overall not needing to go to the emergency room as often, and hopefully there'll be a decrease in their hospitalization events and their days in the hospital if they are hospitalized. So that's really the outcome measure. This is just a way of informing the staff to provide the services to get to that point, right?
I was just trying to say, how can I use this tool to provide better services to my residents, like kind of
Well, I think it's, the tool becomes the vehicle for informing the program staff on what to do,
Yes.
what to focus on, what to prioritize.
Yeah.
I got it, right?
Yeah.
This gentleman right here.
Hi.
Stand up, is that saying? I wanted to speak very briefly about the staff buy-in piece, because I thought it was interesting, somebody back there kind of commented on it briefly. What I thought was interesting is that the purpose of the tool is one that informs case managers what services to provide, but I'm wondering about the participatory piece in the tool and in the development of the tool and in the training of the case managers in being able to implement the tool. So in talking about low, medium, high stability, I'm wondering about the language, number one, and like forming a crisis coordinator
Yes.
position, and kind of what stigmatizing effect that might have on clients. And so I'm just kind of wondering about not just providing the services, but also being able to have somebody utilize the services. So we can provide a lot of different services. We can have the tool be able to say, these are exactly the things that are needed. But on the other end, I think the staff buy-in piece, I think, kind of spoke to that piece of, we can provide the services, but we don't know that they'll accept them. We don't know if individuals will be able to follow through with them. Because of that participatory piece, that individuals might feel stigmatized. Case managers might also kind of feel like, yeah, this is a stigmatizing tool, and therefore the result might be, yes, you need these services, and what does that mean? How does that make you feel? If it makes you feel like you failed, well, sure, you want to not fail, but the end result is over the long term, that individual may not be able to build their own empowerment,
So
be able
is-
to have that be a sustainable result, like good positive gains in the end. That's just kind of what I'm wondering about in terms of when we put these kind of tools together. It's kind of like we're building a path in the city for people to get to a stable place. But if we were to kind of not even create a path, and we were to have just grass and just have a place called stability, and then just see where people and how people get there, I think that that provides the opportunity to be able to see from a more participatory method, how do people get there and how can we support that process? Thank you. Sorry, that was a long kind of thing.
Sure.
I was trying to.
So there seem to be a lot of layers to your question, so I'm going to try and respond to as many as I can remember. The first, so the tool was created and developed and tested and published and all that good stuff. And so there are some parameters around the tool, and the category of functioning is a parameter of the tool. So high, medium, or low are and the scores associated with those categories are part of what the MCAS is. We use it as a shortcut language, just like we all use shortcut language around diagnoses, to inform our work, and it's not language that we use with our tenants. Words definitely have power and meaning, and we're aware of that, but we also need to be able to communicate with each other in terms of what a level of functioning translates into, right? So in terms of staff buy-in and use of the tool and empowering our tenants to choose their own path of recovery, which I think kind of speaks to the concerns that you raised, the tool helps us identify areas where our tenants are struggling. And so it's really an assessment process, as we talked about. And then from that, we work with our tenants to talk about and hopefully join us and identify supports and resources and different ways to struggle less in those areas. So because somebody receives a 3 or lower in a certain category doesn't mean we know how to get them to a 4 or a 5. What we know is that they're struggling, and we'd like to have a conversation about how the tenant thinks they could get to a 4 or 5, or not get to a 2. Right? And so we don't necessarily have a path in each of the indicators to support people. That really is where each tenant's specific situation comes into play. But it helps us be more thorough in recognizing all of the areas where folks may be having challenges.
Young lady right there.
I'm wondering, since this tool is being used by the case managers, they're filling it out. I'm wondering if this also has a supervisory component. In other words, that it helps you guys perhaps then help your case managers develop their own skills and their own depth of learning, then to be able to provide the services that have been identified as client struggles. So it seems that it would have multifaceted impact on both tenants and your staff.
Absolutely.
Yes. It's been huge. It's very powerful.
You had your hand up? You're done? Yeah, you had your hand up before.
So you started this assessment with the SMI population, you went to SUD. How translatable would it be to other conditions, like an HIV/AIDS population or other serious conditions that are chronically affecting a person's lives? How can you kind of change it, or how much work would that be?
Sure. Okay. So in some of our congregate programs, we do have clients or tenants who don't have a substance use disorder or a mental illness. So we're already using it in that respect. And
Off-label.
Off-label.
Right.
It's our best practice. With the understanding that it's not used in the evidence base that it was intended. But what we found is we're getting very accurate and still good results in that respect. And the one question, acceptance of psychiatric disability, is really the only one that, you know, we have to tinker with a little bit. And for that, we just say acceptance of disability or disabling condition, whatever it is that landed them with our services. And they're not all high functioning either. Just because they don't have a mental illness or substance use disorder, they're still scoring lower and medium functioning, and there's still goals that we're able to work with them on in that respect.
Right. I think that generally speaking, for all of us, is that we are working with people with very complex care needs, and they're usually, cross over. So that even though the person with HIV/AIDS may not have a diagnosed psychiatric disability, they may have an implied psychiatric disability that just isn't the reason they got into the program, but it's still there. So I think that what you're doing makes a lot of sense. Yes.
Do you have any recommendations for us on how we could start up something like this? Like, how high tech do you need to be? I mean, you were talking about embedding into awards. I mean, do you need to do this all on computer, or is there some paper versions available? Where do we start?
Yeah, it was developed on paper. Our focus of wanting electronic capability was so that we could really use and play with the data in a way that having a pile of evaluations in the corner of my office doesn't enable us to do much with. And so for those of you familiar with awards, with the form builder function, we were able to get it into awards very simply. We've now uploaded the MCAS manual into awards so that staff have immediate access to it wherever they happen to be working on it, and don't have to carry the paper version around with them. And so having it in awards allows us to do all the fun Excel stuff that you saw without kind of somebody else doing data entry later on. Really helps us capture that historical information. But totally, it's developed as a paper tool.
Something to kind of tag on to that is, you said it was in the public domain, so you can get it for free, but is there a training?
Affordably.
It is affordable.
There is a cost to it.
There is, yes.
Is there a training component that comes along with it, so whoever is implementing it, I mean, do you go to Oregon and go to a training?
No. I'll let Heather speak to this because she's our training guru.
What's that?
I taught myself. So I based the training on the manual. It's very comprehensive. It's about 40 or 50 pages, and I just took all of the salient information about a lot of what you saw in here. When do you use it? How is it developed? And we go over each of the indicator items, and we do case examples of real tenants, and it actually also comes with a video. So you can watch how people rate it, and then you can apply the skills better, and we can have those conversations if they disagree with me, which they often do, about, well, why are you rating that person that way? And we do the training, the initial orientation, and then every 6 months we do a refresher course. And the longer they've been doing it, the more clinically based we make the training. And we've been tailoring it over the last couple of years, and now I feel like we have it down pat now.
Yeah. So it's a fully self-credentialed process. It's not a train the trainer, it's not go to Oregon, and that is huge.
I was just wondering, are you using this in lieu of a functional assessment, or are you still doing a functional? Okay, so
This is our functional
This is your
assessment.
new functional assessment. Okay.
Go ahead. No, either one.
I was just wondering if you were talking about, I know the matrices in process, but
You need to speak a little louder, because I don't
have there
think...
been any cases of, prevention due to the tracking and the data?
Has there been a prevention due to the...
I think the question is, what predictive value, what is the predictive value in terms of preventing?
Further to compensate.
That would be you.
Yeah.
That would be you.
I think that kind of tracking people over time, if we do see that 10-point decrease, we can kind of, if they're not already on my radar, kind of through case managers, assessments, or people kind of calling me and telling me what's going on, we can kind of see that and then make sure that we're still providing outreach, we're still providing clinical interventions to them, so they don't end up in the hospital or kind of needing a higher level of care. So it's something that we continue to monitor, and that it really, I think, has helped with keeping people out of the hospital. Does that answer your question?
Yeah.
And certainly, in HomePlus, we're about a bit over 2 years in. And the first year was just true implementation. We were all trying to figure out what we were doing and how to get accurate scores and how to address rater bias. And so in a way, that the data from that first year isn't reliable for us to compare to. And so we're at the point where we can really get savvy around identifying potential red flags and providing more wraparound services. And so that's kind of currently where we are. With our congregates, because we've learned so much implementing in HomePlus, we don't have that year worth of kind of starter data. And so we're going to really start being able to be savvy with those tenants much quicker.
In the aggregate, does your data show that people scores increase, say, from day 1 of admission to, say, day 365?
Well, because of rater bias, the scores have actually decreased, and that's a good thing. We're getting more accurate information, right? So everybody was kind of overrating their tenants initially, and so like everybody was high functioning, which was not accurate when we looked at the folks that we were working with. And so one of the ways we kind of alluded to in the presentation was I would ask the case managers, who are your toughest cookies, right? Who's really struggling right now? Great, give me these 5 names. Let's pull their MCAS and see where the disconnect is around stuff. And through that, we got to really fine-tune how we were using the tool and how we were working to make sure it accurately represented the struggles that some of our tenants were facing.
Can you speak about the time implications for the workers and how that was managed and how that impacts the program?
So originally, when case managers were learning how to use this tool, it was taking a long time for them to do because you have to use the manual and go over every specific item and make sure you're rating it correctly. And when we discussed it as a team, our first kind of team meeting going over all the MCASs took a full day. There was a lot of conversations back and forth, people kind of defending their scores. Now that we've been using it for a long time, it takes about 10 minutes for a case manager to complete, depending on how well they know the tenant. Obviously, our new tenants, we use the semi-structured interview, and that requires more time to have that conversation with them and then go back and fill out the tool. But now it's about 10-15 minutes, and we do it every 3 months for every tenant in conjunction with our service plan.
I don't have any idea what your turnover is. I'm just curious, though, if you think that staff seniority has any impact on your data?
What do you think? You say first, and then I'll say my opinion.
I don't think so. I don't know that it's something that we've looked at per se, although we could, because we know who the case manager is who completes all of the tools. And I think because we do both a credentialing and a review process every 6 months, and we have that available to folks pretty, within a month of when they start, they're getting trained on the MCAS. It's just kind of real and alive for everybody. And again, the MCAS is not something you can do based on your gut. As a licensed social worker, I was going through my self-credentialing process, and I was like, oh, I got this, and I was filling out the tool after I watched Beth's case vignette, and I failed because I was not staying true to the tool. And so it is really just staying true to the tool, and with that, whether you're seasoned or day 2, as long as you're following the tool, you're doing it accurately.
Being in this integrated rewards, how do you capture the data? Is it through awards, or do you do that through a secondary database?
No, it's all actually completed in awards. We complete the MCAS in awards. We don't do anything on paper. Then we print it out for the charts. But.
Any other questions? Yes.
I guess I'm just wondering if you've considered renaming this process in terms of the title of this presentation was How Are Tenants Really Doing? And it seems more that it's about how staff are doing in evaluating the tenants within your framework. Because if it doesn't include the component about including tenants, it seems somewhat illusory to me. Because if you're not asking tenants anywhere in the process, how are they doing? How are you really doing? Say, for example, someone who decided they didn't want to take medication as part of their process in recovery. I don't know how they would score or how the medication questions are, but it seemed, before it seemed to be suggested that that would be a score, that would translate into a score of medication compliance. So if their idea was to not take medication, I'm just thinking it's not really about how they're doing.
Well, if someone is actively prescribed medication, then we evaluate how they're doing in terms of taking their medication as prescribed. And that is one of 17 indicators that speaks to somebody's level of functioning. And if you're prescribed medication, then whether or not you're taking it is likely going to impact your functioning. Now, if somebody's not prescribed medication, they get a 5 on that. Doesn't mean they don't need medication, maybe, or wouldn't potentially benefit from medication. But if they don't have an active prescription, they get the highest score possible. And so the MCAS, and this is where we've had some really lively discussions with the staff, is that it is a non-judgmental tool. It's not about whether somebody should be on medication or wants to take medication or needs to take medication. It's just, if they're prescribed, are they taking it as prescribed? And there's a range in terms of how often and the whens around that. And all of that is based on our conversation with our tenant. And so if somebody's kind of whatever their situation is, it's all a conversation. And so if you're not prescribed medication, it's, well, what do you think about that? Are you still comfortable with not being on medication? Or would you like to explore being on medication? If you're prescribed something but not taking it as prescribed, well, let's talk about that. So I think we have used the MCAS as a tool to really dig deeper into those conversations with our tenants, and it's all based on their experience, and therefore I think it is about how they're doing. So that's just my opinion.
Yeah, I think that I have a question.
Okay.
Which really has to do with your question. Which is sort of the interface between this kind of evaluation or functional assessment and recovery. And I think that you've sort of spoken to it. I heard you say also that it's not necessarily the case that the tenant will prefer, that the tenant's preference will be to pursue a goal that the MCAS prescribes. That the tenant has the option to say, I don't want to do this, but you would still include it in the goal plan.
We would include it somewhere on the service plan.
Right.
Our service plans include both tenant strengths and tenant challenges. And so if somebody is not doing well functioning in a certain area, then it's a challenge. And we acknowledge that.
Right.
Right? I don't think we should be shying away from that.
No, I just think that there's a distinction between adherence and function and ability. So a person, for example, may not adhere to a medication regimen, but they may be functioning quite well. They may be working.
Yes,
they may
yes.
But that's but you said you handle that through a conversation. So the
Yes.
person in that conversation might say, I'm not taking my medication because I don't really feel I need it. I'm doing well.
Right.
That's a great conversation to have.
Right.
Because then you explore that and you go more deeply into that. Well, what is it that makes you think you're doing well? Give me your indicators, what you see yourself as doing well, and so on, and.
Right. And all of that will be reflected in the other 16 questions on the MCAS.
Right. Go ahead.
I think for me, at least, I was a little confused because it seems like it's a great tool to have your staff become more clinically sound, and as a supervisory tool perhaps. However, for our program, I think we'd like to see something where the tenant can self-evaluate and how are they assessing themselves. So I don't know, does that tool allow for, yes, the conversation happens, but the tenant isn't even aware that they're being measured in this way, it seems.
There's a self-report version of the MCAS, and so I think that would be an interesting thing to have them sit down and then have a conversation and about why they're rating themselves as they are. And we haven't used that yet, but we were too worried about getting step 1 done.
We needed to learn it first.
But there is a self-report version.
I would be interested in coming here next year and hear you talking about that. Any other we have a question back there.
Okay, being that the client, the case managers are just getting to know the client, at some point, do they have to refer back to the HRA packet to get some information that the client may not reveal during the initial conversation? I'm just wondering, because if the clients are not involved and you're doing this during intake, how are you able to actually answer these questions if you're just getting to know the client?
Well, we use a semi-structured interview that is a suggested tool as part of the MCAS manual. And when we say we do it part of intake, it's kind of within their first week or so in the program. It's not part of kind of the application interview process. And it's actually a really wonderful way for the case manager and tenant to start to connect with each other and talk about how they're doing and what we can help them with. And I think it's a fantastic first conversation.
Yes.
Yeah, I just want to clarify, you don't use this data for like program outcomes, or you are able to, like, because you said that the functional level might go down actually. So it's like, how do you measure the success of your program? Is that too much to ask again?
Well, BRC has a number of performance indicators that's specific to program and program type. Stability is one of our dashboard measurements for our permanent supportive housing programs, including the other measures are usually occupancy rate, right? If we don't have tenants to serve, we're not doing well. Percentage of folks paying rent on time, percentage of service plan goals with progress or attained, stability. And so whereas some of the other measurements have very clear goals, right? So 95% minimum occupancy, 95% minimum rent payment in our congregates. We should be so lucky in our scattered sites. Stability is a measurement where we, especially with this process, have been wondering if we should have a goal assigned to it, or if it's something we should just continue to be mindful of. For example, one of our congregate programs is for folks who are 55 plus, and it opened in '94, and we have some original tenants. And so folks were on the older end of things when they moved into us. They've now
Watch it.
been with us, older. And they're folks with a homeless history, right? And so we know that being street and shelter homeless and mentally ill and likely substance abusing, right, all of that impacts your life and your health. And so despite our best efforts and our tenants' best efforts, they're aging and there are complications in that aging process. And so the stability rate is decreasing, and that's just reality, and there's not anything really we could be doing differently around that. But knowing that the stability rate is decreasing helps us think about it, right? Keeps it on our radar and helps us keep questioning, can we be doing something differently, right? Does everybody have a home health aide who should or who will, right? Do we have the Meals on Wheels and God's Love We Deliver, all of that in place? And so we're keeping it on the dashboard, but are considering, it's not about managing with the number, so it informs our work.
So considering the fact we have different types of clients, do all of them have treatment plans? And if they don't, how does the tool, does it decrease its effectivity?
We encourage all of our tenants to participate in our service plans. Many say yes, some say no, and we keep asking. But we do the MCAS independent of whether or not somebody will work with us on a service plan.
Also, just because no one's really asked, I'm curious, you mentioned briefly cost, both initial output and how it might correlate to savings down the road.
Do you know the initial cost? I know it was affordable. I don't remember the exact cost. You buy the actual kit. It comes with
The training DVD.
Training DVD, several manuals, then you can copy them for use within your program. And that's the initial cost. And then it's just staff time. Really, so kind of the level of training that we do, and our implementation and kind of what we pull out in the data. So all of that is, soft costs. It's all staff time and attention. I don't know that there's really a way for us to measure saving money in an ongoing way.
Well, you may be saving the system money.
Yes. But again, there's no way, if we're preventing,
the one thing that
it's hard to
the one thing that you could do is you could, from year to year, as a result of using this intervention, you could see what your aggregate hospitalization event and days has been. So you could see whether the tool has been effective in your overall goal, which is to keep people healthier.
Oh, great.
Any other questions? Oh, we have one more.
Is this tool reflected at all on staff performance of best practice over a period of time?
I'm not sure that I'm clear on your question. Can you tell me a different way?
If there's staff have 15 clients that they have to assess, and if there's a particular staff person whose clients are continually rating low, does that reflect on the best practice that they are providing to the clients?
No. Hopefully not.
No, I don't think we found any patterns around that. I mean, certainly, if we identified that somebody's caseload was all low functioning, other than Lynden's, whose job it is to have low functioning folks, then we'd want to look at that, right? And so maybe it's kind of a randomly unfair distribution of folks, that we need to do something different to ensure that staff person doesn't get burnt out. But again, I mean, that was some of the rater bias that folks were speaking to, is that they didn't want to kind of reflect poorly. Like, they had an investment in their tenants scoring highly to kind of show that they were doing good work, and that's not at all what the tool is about. A staff member could be doing the most amazing, best, just fantastic work, and a tenant can still be struggling because that's they're a tenant and they're struggling, and that's why they're in our program. So no.
Okay, we're going to stop. I'd like you to help me thank these folks for